alterations of renal and urinary tract function. Urinary tract obstruction refers to any blockage that interferes with the normal flow of urine at any point along the urinary tract. These blockages may be caused by anatomical abnormalities or functional defects, collectively known as obstructive uropathy. The impact of the obstruction depends on its location, severity, and duration. Prompt recognition is crucial to prevent irreversible kidney damage. The severity of a urinary tract obstruction is influenced by several factors. These include the specific location of the obstruction, whether it is complete or partial, and whether it affects one or both ureters or kidneys. The duration of the obstruction and its underlying cause also determine the extent of damage. Evaluation of these aspects helps guide treatment decisions. Obstructions in the upper urinary tract can result in significant anatomical changes. Conditions such as hydroureter involve dilation of the ureter, while hydronephrosis is the enlargement of the renal pelvis and calyces. When both structures are dilated, the condition is known as ureterohydronephrosis. These changes can lead to increased pressure and loss of renal function if not addressed. Upper urinary tract obstruction can lead to several significant anatomical changes in the kidney and ureter. Hydroureter refers to the dilation of the ureter due to urine buildup, often caused by a blockage downstream. Hydronephrosis occurs when the renal pelvis and calyces enlarge, also due to obstructed urine flow. In more severe cases, ureterohydronephrosis develops. This involves dilation of both the ureter and the entire pelvic system, potentially threatening kidney function if not treated promptly. The body attempts to compensate for unilateral obstruction through hypertrophy and increased function of the unaffected kidney. This compensatory mechanism is driven by growth factors that enhance filtration and workload. After relief of the obstruction, patients may experience post-obstructive diuresis, a period of rapid urine output. Kidney stones are also a common cause of upper tract obstruction and will be discussed next. Kidney stones, also known as nephrolithiasis or urinary calculi, are solid masses formed from crystals, protein, or other substances. They can obstruct the urinary tract and cause intense pain. Risk factors include age, sex, race, genetic predisposition, diet, hydration, occupation, and geographic location. Stones are classified by the minerals they contain, such as calcium, uric acid, or struvite. Stone formation begins with the supersaturation of salts in the urine, where their concentration exceeds the urine's ability to dissolve them. These salts may then precipitate, turning from liquid to solid, and grow via crystallization or agglomeration. Factors like reduced levels of stone inhibitors and urinary stasis can increase risk. The retention of particles and presence of matrix materials also contribute to stone formation. Patients with kidney stones often experience renal colic, a sharp, cramping pain due to ureteral spasms and distension. Diagnosis involves imaging and 24-hour urine analysis to determine the stone's composition and contributing factors. Treatment focuses on increasing fluid intake, limiting dietary intake of stone-forming substances, and in some cases, surgical or procedural stone removal. Preventive strategies are key to avoiding recurrence. Obstruction of the lower urinary tract may result from anatomical issues like urethral stricture, prostate enlargement, or pelvic organ prolapse. These cause partial blockage of urine flow, leading to symptoms such as frequent urination, nocturia, urgency, and weak urine stream. Patients may also experience incomplete bladder emptying. An overactive bladder can mimic these symptoms without a structural cause. Neurogenic bladder results from nervous system disorders that affect bladder control. In detrusor hyperreflexia, the bladder contracts too frequently, sometimes with vesicosphincter dyssynergia, a lack of coordination between bladder and sphincter. Detrusor areflexia, on the other hand, involves an underactive bladder that fails to contract effectively. These patterns often appear in spinal cord injury or neurologic disease. Kidney tumors include renal cell adenocarcinoma, renal adenomas, and renal transitional cell carcinoma. Bladder tumors, especially transitional cell carcinoma, are the most common and typically present with painless, visible blood in the urine. They are more frequent in males over 60 and are strongly associated with smoking. Early detection is critical for improving outcomes. A urinary tract infection is an inflammation of the urinary epithelium caused by microbial invasion, most commonly bacteria. UTIs can be classified as uncomplicated or complicated, depending on whether the urinary system is otherwise normal. Complicated UTIs are associated with abnormalities or comorbid conditions that impair immune defenses. Prompt treatment prevents progression to upper tract infection. Types of UTIs include cystitis, an inflammation of the bladder typically caused by E. coli or Staphylococcus saprophyticus. Symptoms include frequency, urgency, burning during urination, and lower abdominal pain. Antibiotic therapy is the mainstay of treatment. Identifying the causative organism helps guide effective antimicrobial therapy. Interstitial cystitis, or painful bladder syndrome, is characterized by chronic bladder pain without evidence of infection. It is most common in women between the ages of 20 and 30. Symptoms include bladder fullness, urinary frequency, small voided volumes, and persistent pelvic pain. There is no definitive treatment, and management focuses on relieving symptoms and improving quality of life. Acute pyelonephritis is a sudden infection of the ureter, renal pelvis, and interstitial tissue of the kidney. Common causes include Escherichia coli, Proteus, Pseudomonas, and vesicoureteral reflux. Symptoms include fever, chills, flank pain, and urinary urgency or frequency. If left untreated, the infection can become chronic and lead to kidney scarring. Chronic pyelonephritis is a persistent or recurring infection that causes progressive inflammation and scarring of the kidneys. It may be idiopathic or result from repeated acute infections, vesicoureteral reflux, or the presence of kidney stones. Over time, chronic pyelonephritis can lead to loss of kidney function. Early intervention and treatment are essential to limit long-term damage. Glomerulonephritis is inflammation of the glomerulus, the filtering unit of the kidney. It can be classified as primary, affecting only the kidneys, or secondary, associated with systemic diseases. Immune responses, including deposition of immune complexes or antibodies, are central to both forms. Glomerular injury disrupts filtration, often leading to protein and blood in the urine. Severe cases of glomerulonephritis present with two hallmark symptoms: hematuria, often with red blood cell casts, and proteinuria exceeding 3 to 5 grams per day. Additional signs include oliguria, hypertension, and edema. The urine may contain nephrotic or nephritic sediment, depending on the nature of the inflammation. These features help guide diagnosis and treatment decisions. There are several forms of glomerulonephritis, including membranous nephropathy, rapidly progressive glomerulonephritis, and antiglomerular basement membrane disease, also known as Goodpasture syndrome. Chronic forms, such as chronic glomerulonephritis and diabetic nephropathy, evolve over time and contribute to progressive kidney damage. Management often includes immunosuppressive therapy and control of underlying diseases. Monitoring for progression to chronic kidney disease is essential. Nephrotic syndrome involves the excretion of more than 3.5 grams of protein per day in the urine. It is more common in children and may result from primary causes such as minimal change disease or focal segmental glomerulosclerosis. Secondary causes include systemic illnesses like diabetes mellitus, lupus, and amyloidosis. The massive protein loss leads to hypoalbuminemia and edema. Nephritic syndrome is marked by hematuria and red blood cell casts in the urine, and it tends to be less severe than nephrotic syndrome. It commonly occurs in response to infections and autoimmune conditions. The underlying pathology is inflammation, which causes capillary damage in the glomerulus. Protein loss is usually moderate compared to nephrotic syndrome. Common findings in both syndromes include edema, hypoproteinemia, and proteinuria. Other features are hyperlipidemia, lipiduria, and in some cases, vitamin D deficiency and hypothyroidism. These reflect systemic consequences of protein loss and altered kidney metabolism. Treatment focuses on addressing the underlying cause and managing symptoms. Kidney dysfunction ranges from renal insufficiency to acute kidney injury (AKI) and end-stage kidney disease. Uremia refers to a clinical syndrome caused by the accumulation of toxins due to kidney failure, often accompanied by fatigue, nausea, and mental status changes. Azotemia is a related laboratory finding, indicating elevated blood urea nitrogen and creatinine. Identifying the stage of dysfunction guides therapy and prognosis. AKI is a sudden and often reversible decline in kidney function. It is characterized by reduced glomerular filtration and urine output, as well as a buildup of nitrogenous wastes in the blood. The Reifel criteria, risk, injury, failure, loss, and end stage, are used to classify the severity of AKI. Prompt diagnosis and management can often prevent permanent kidney damage. Prerenal AKI is the most common type and results from impaired blood flow to the kidneys. Causes include hypotension, hypovolemia, sepsis, heart failure, or renal vasoconstriction. The glomerular filtration rate drops because filtration pressure is reduced. If not corrected, prerenal injury can progress to ischemic damage. Intrarenal or intrinsic AKI often results from acute tubular necrosis, either due to ischemia or exposure to nephrotoxic agents like certain antibiotics or contrast dyes. This type involves direct damage to the kidney tissue itself. Postrenal AKI, on the other hand, is caused by obstruction of urine flow, commonly from stones, tumors, or strictures affecting both kidneys. Timely removal of the obstruction can reverse the damage. AKI frequently presents with oliguria, a marked decrease in urine output. Several mechanisms contribute to this: changes in renal blood flow, tubular obstruction, and backleak, where filtered fluid leaks back into the bloodstream. The duration and severity of ischemia determine how long the kidney remains dysfunctional. Early intervention can shorten recovery and minimize long-term effects. AKI progresses through 3 phases. The initiation phase begins with the injury itself, when early detection can prevent worsening. The maintenance phase is characterized by low urine output and rising levels of BUN and creatinine. In the recovery phase, kidney function returns and diuresis occurs, with a decline in serum toxins and gradual improvement in filtration. Chronic kidney disease, or CDK, is a progressive, irreversible loss of renal function that affects nearly every organ system. It is commonly associated with hypertension, diabetes, or intrinsic kidney disease. CKD is staged based on glomerular filtration rate, from normal or greater than 90 ml/min to end-stage renal disease or less than 15 ml/min. Early stages may be asymptomatic, but late stages require dialysis or transplantation. CKD gradually develops over months or years. As nephrons are lost, the remaining ones compensate, delaying symptoms until the disease is advanced. The progression may be silent at first, but biochemical abnormalities begin to emerge. Intervening early in the disease process can slow its course and preserve function. Two key factors that worsen kidney damage are proteinuria and elevated angiotensin II activity. As GFR declines, levels of creatinine and urea in the blood rise. Angiotensin II promotes inflammation and fibrosis within the kidneys. Therapies targeting these factors, like ACE inhibitors, can help delay disease progression. CKD affects fluid and electrolyte balance. Initially, sodium excretion increases with water loss, but later the kidney loses the ability to concentrate or dilute urine. Potassium secretion rises early on, but is retained once oliguria develops. Metabolic acidosis may occur when GFR falls below 30 to 40% due to impaired hydrogen ion excretion. Disturbances in calcium, phosphate, and bone metabolism are common in CKD. Reduced phosphate excretion and low vitamin D activation lead to hypocalcemia, increasing the risk of bone fractures. CKD also disrupts protein, carbohydrate, and fat metabolism, contributing to dyslipidemia. These changes raise cardiovascular risks and affect nutritional status. Chronic kidney disease impacts nearly every organ system. The cardiovascular system may develop hypertension, heart failure, or pericarditis. The pulmonary system can be affected by fluid overload, leading to edema and pleural effusions. Other complications include anemia, immune dysfunction, neuropathy, nausea, reproductive disturbances, and changes in skin integrity such as pruritus and pallor.